I don't know if you have a tradition of pantomime in your country, but in England it's part of the comedy at Christmas, you know, that somebody is always behind someone and everybody in the audience can see that they're behind, but the person who's speaking can't. So I was sneaking in behind. Okay. So my name's Robert Johnstone. First of all, thank you to everybody who's stayed so long. I'm looking at the numbers and seeing they're down a little bit. It's interesting, there's a phrase that seems to be used in every culture, last but not least, so hopefully I fit into that category. My name is Robert Johnstone, as you said, from the International Alliance of Patients Organisations. My colleague, my co-rapporteur, has perfectly illustrated the nature of pain because she has gone down with a sort of flare situation. So unfortunately she's not available. And although she was at the session yesterday and we took notes together, then it's all fallen to me this afternoon. But that's fine. So I wish Gina well as soon as possible. First thing I want to do is to say that in trying to summarise a series of presentations from 12 presenters, I couldn't possibly mention them all or do justice to them all. So what I've tried to do is just produce 2 or 3 slides where we try and summarise the general messages that are coming through. And occasionally I will refer to the country from which the speaker came, but very often I will just gather things together in one point. Okay. Good. So the first area that we wanted to look at in terms of looking at the future for pain management, we felt it was very important. We had a number of speakers who were talking to us about the cost of not treating pain, the cost of pain to society, not so much the cost to the individuals. We all know experiences of that. And so I've just chosen a few figures from one presenter because I think this illustrates what many presenters were saying. And as you can see, this is just looking lower back and joint pain in Portugal. The figures they came up with in terms of work loss was 460. This is the indirect costs of pain, of course. We can all quantify the direct costs. But the indirect costs of work loss, 460 million euros, of absenteeism from work, 280 million euros, total 740, representing 7.5% of health expenditure, almost 0.5% of GDP. But that was what this study was about. They didn't include all causes of pain. This was only lower back pain and joint pain. So when you bring in the other causes of pain as well, the estimation is that 0.5% of GDP would rise to 1.7% of GDP. We also quickly Googled what the GDP of Portugal was and came up with 238 billion euros. So just to give you an idea of the figures. But we also, in discussion afterwards, pointed out to the speaker that although she was looking at work loss and absenteeism, there is another hidden cost in the sense the number of people who, with severe pain, still manage to get to work, they just don't perform very efficiently because of the pain. And certainly I've heard that described in the phrase presenteeism. You're there, you're presenting in work, but you're not really there. And again, as somebody who's lived for 57 years with a chronic condition, I have days when I'm not really there. You know, I may be sitting there, I may even be smiling and saying hello, but I'm not working at full efficiency, by no means. The other thing is that this particular study had not done is to look at the non-labour costs, the non-labour market costs of pain. So for those people who aren't in paid employment but support society in other ways, the carers, the mothers, the carers of older people, those who are in volunteer work, you know, what is the cost to society of those people being in pain? And so, you know, by the time you add all those things together, who knows, but it's going to be a considerable proportion of GDP. So the point is that the first category was identifying the real cost of pain and therefore the real need to do something about it. So that's a number of speakers. Sorry, I've jumped. The second series of speakers was looking at the value of establishing the costs and the benefits of treatment. So using health technology assessment in individual countries or in individual situations, and also establishing networks that can compare health technology assessment measures across countries. So those techniques, the rise of HTA, can really help work out what is the most cost-effective treatment. And also we talked about, different speakers talked about quality registries. So this is registers of pain clinics, of treatments, of practitioners and so on, nationally, because we recognise that, of course, health is it's the state responsibility or sometimes the regional responsibility, but comparing good quality across the country and across Europe. And then we looked at registries to establish and share good treatment practice. And we heard a very good presentation. Again, I'm just choosing one of the many presentations to illustrate this, where a doctor from San Marino was talking about the value of using non-steroidal anti-inflammatory drugs and opioids and comparing the two. And although the research indicates, the best practice guidelines indicate that opioids have relatively few side effects, so they're a relatively cost-effective treatment for pain, in practice, the first 10 pain treatments on the National Register were non-steroidal anti-inflammatories. So even though there is good practice, it's not necessarily being shared and it's not being put into practice. And the final area where we looked at networks was pain therapy networks to support the doctors and practitioners. Because there was one very good study from an Italian doctor who was pointing out that actually it's not only the cost to the individuals living with pain, it's not only the cost of those people in society, it's the cost of the practitioners who are treating these people. And that actually many of them, it's working in a very intensive situation. Many of those people become really affected by the problems of the people they're working with and the difficulty of not being able to treat effectively. So a lot of stress is transferred to the doctors and the practitioners, and it is possible to do something about this. So again, to share good practice to alleviate the stress of the practitioners. And I think finally the thing that came out, this is my last slide, is that whatever we're looking at, as I say, out of 11 or 12 presentations, whether people were focusing on health technology assessment or other issues, the importance of patient-centered care came out. This is not something where the practitioner can look at a selection of symptoms, prescribe a treatment, and walk away from the situation without actively involving the patient in the process. If you do, it may be marginally effective, but it's nowhere near as effective as it could be if you really embrace the principles of patient-centered care. And moving on, other people were talking in their presentations about the sort of, the mind, body, spirit approach, the biopsychosocial model, however you want to look at it, but this is the most effective treatment style, and it's been empirically proven to be such. And there were examples, and again, because I work at a European level advocating for patients, it's very interesting that, one of the examples that we had on this came from Spain, from Southern Europe, but the other example came from Sweden, from Northern Europe. So, there are some things which are cross-cultural. And we had a great quote illustrating this again from a French doctor. It's good to be better, but it's better to feel good. And again, I think this illustrates the sort of biopsychosocial issues. We also heard a couple of presentations where we were looking at outcome measures in terms of pain treatment, but it was emphasized again and again that it's what the patient feels is of value that is the final deciding point. So the use of things like patient-reported outcome measures to assess the success of treatment. And we also saw from a number of presentations about how it wasn't just a clinical situation of treating pain, the patient even feels better. It's a question of then allowing that patient, that person, to reintegrate into mainstream society, because that's the future of the successful treatment. So it's the autonomy of the patient in society that is the important final issue. And just finally, I'd just like to comment slightly on the whole conference, if I may take a moment. Because I've been working as a patient advocate for about 12 years now, and before that a disability advocate, just to comment on the audience that I find myself with in this situation. Often we as patient advocates, it's slightly, or sometimes very, adversarial towards the doctors. I just have to say very clearly that that is not the case in this conference. I often use the example when we're talking about patient-centered care and shared decision-making and so on. An example I heard at a conference a couple of years ago, that in order to get this true partnership between patients and doctors, the quote goes that the doctors have to come down off their pedestals, but the patients have to get up off their knees. Now, we work on getting the patients off their knees. It's up to you, medical professionals, to make sure you and your colleagues come down from the pedestals. But in this audience, I do not see that. I do not see the doctors on pedestals or the patients on their knees. And that's quite unusual. I've been at a number of national and international conferences, and that very often tends to be that hierarchy. And I don't see it here. And I think that's a great success you already have. And if you can share that with the rest of the medical and patient world, you're doing very well. Finally, I'd just like to comment, in the presentations generally, people have been talking about the role of pain in society and so on. And I think we have to be very careful with this old phrase, no pain, no gain. I think that is talking about short-term pain in order to cause some pressure and allow people to succeed. I don't think it's talking about chronic pain. We do have to eliminate, as much as possible, the experience of chronic pain. Chronic pain does not lead to gain. Chronic pain leads to misery. Misery for the person who's experiencing that pain, misery for those around them, misery to the whole economy. And patients, people living with these conditions, are part of the solution, part of a happy, healthy society. Yes, we can accept pressure to achieve short-term results, but no to chronic pain. And I think that's how I'd like to finish. Thank you very much.